All right, good afternoon, everyone. We're going to just ask the panelists if they can sit down. And all right, let's get to our session. Don't forget about the gala. We have, as usual, Dr. Bob Stoller, who's leading many efforts here in Texas, but he's going to be talking about renal denervation for us as the first talk of this afternoon, innovations in cardiovascular intervention. Thank you, Bob.
Thanks for having me. Thanks for inviting me, gentlemen. So a couple of cases for you, a little bit unusual. First one, 61-year-old diabetic, coronary disease and severe resistant hypertension. Blood pressure's well above 160. You can see he's on basically 5 meds, type 2 diabetic on metformin. He comes to the office asking for renal denervation. After discussion, given his diabetes, he consented to be in the Spiral Gemini trial. What is Spiral Gemini? It's a trial of hepatic denervation in addition to renal denervation to treat hypertension. You zap both kidneys with the Spiral protocol, and then we do a 4-electrode ablation of the common hepatic artery. So for questions like you guys, this isn't an important question, but for someone like me that doesn't spend time in the peripheral world, the big question is, where the hell's the common hepatic artery? And how do I get there? So to remind you from your med school days, the common hepatic artery comes off the celiac trunk. I don't really have a pointer, but the left gastric artery goes up and around to the left. The splenic artery comes out to the patient's left, and the common hepatic artery goes out to the right. Do I?
The pointer is this one right there.
Oh, Subhash lied to me. Okay, so the left gastric, the splenic, and the common hepatic. Okay, so now that we sort of know where they are, how do you find them? Well, you start with an aogram, and you can see coming up here, the splenic comes off this way, the hepatic goes off that way, and you can kind of see the gastric ghost up there. And what you do is you take a short IMA guide, you find the celiac in AP, it sits just below the diaphragm, and the catheter likes to pop right into the splenic, I learned from my N=1 experience. And you counterclock the catheter, and it takes you right into the common hepatic. And for hepatic denervation, as for a lot of my denervation cases, a buddy wire, if you're an operator, is your good friend. Buddy wires help keep your catheter stable and keep you where you want to be. So I went ahead and put a buddy wire in the splenic, counterclocked the catheter, and put my workhorse wire in the common hepatic. The spiral catheter, if you aren't familiar with it, is obviously spiral shaped, but it has 4 electrodes that sit up against the arterial wall and use radio frequency energy to ablate. There are 2 generators for this procedure. There's a special one for the hepatic, and there's the usual one for the renal. These patients are uncomfortable, and one of the things we've learned to do is put them on a ketamine drip, because they can be fairly miserable when you're denervating their renals. So here is so you can see here I've got my spiral catheter in the common hepatic, 4-electrode denervation. Take another picture of the hepatic. Looks great. That's a wrap. We're done. This was the first Spiral Gemini on meds done in the world. So we're learning. I'll be curious to see what happens to his high blood pressure with that. That's how you get into the hepatic. So I got a second quick case for you. 45-year-old woman with malignant hypertension comes in, no other comorbidities, on a boatload of meds, labetalol, nifedipine, and ARB, hydralazine, spironolactone. Secondary workup's all negative, and she's referred for inclusion in AFFIRM, which is the renal denervation trial that I'm sure all of you guys have heard of. So taking our pictures, most of you as peripheral docs in the audience are going to know what you see, and what you see is fibromuscular dysplasia. So the big question Next is, what are you going to do? What do you do with this? She's clearly a screen failure for Affirm, right? FMD, which didn't show up on her renal Dopplers or anything else, is a screen failure for Affirm. So should you dilate it or just leave it alone? Well, that's the question I ask. So I asked a couple of my smarter peripheral guys, and they told me I needed to put a flow wire down there and measure the gradient and get an FFR. And just to give you a reference, there's a fair amount of data out there. But for the most part, when we're dealing with FMD in these kind of patients, generally the indication for PTA seems to be a gradient of greater than 10 to 20, an FFR number less than 0.9. And in this patient, all of her gradients and her FFR numbers were normal. So what am I going to do with her? The family's really, really disappointed. She's very young. She's got aggressive hypertension. I talked to them. So it turns out at the end of 2023, both the ReCore balloon system and the spiral renal denervation system from Medtronic were approved. So I promised this patient that she could come back and she would be my first commercial renal denervation. And I chose the spiral device because I think it has better BP reduction, at least. They've never been compared head to head. It's not necessarily fair to say, but when you look at the two sets of trials, it seems like the spiral device may have a bigger delta in blood pressure. Renal denervation essentially always works. It's always on. You see the left side is treatment, the right side is sham. And when you look at sustained BP reduction in resistant hypertension patients in the GSR defined, what you see is out to 3 years, some of these patients in terms of office BP get something like a 20, 25 point drop in their systolic BP, which is pretty important and pretty impressive. And in terms of 24-hour ambulatory BP, the drop is greater than 10. So I thought that was a pretty reasonable choice for her. So we brought her back. I did 5 catheter positions, total of 20 ablations on the left side. There's her baseline on the right. Did 4 catheter positions, 4 ablations per position, so 16 ablations on the right. And she did great. And since this is an operator's enclave, a couple of tips and tricks for doing renal denervation. I use a short IMA guide. I use an 014 support wire. I generally use an Ironman, but you want something stiff to deliver the catheter. And once the wire goes in, you're not going to be able to steer it. It's not a coronary case. So you use the shape of the catheter, torquing it to and fro, or moving it back and moving it forward to aim where you want to shoot the wire. And once you get the catheter aimed where you want it, you can send the wire where you need it in any particular branch. So follow-up for this patient, she was done in November 2023. We saw her back in April 2025. She felt great. Her blood pressure was consistently less than 135/80. Her meds had changed to metoprolol and ARB and spironolactone. She was no longer on her labetalol, no longer on her nifedipine XL, and no longer on her hydralazine. So conclusions, what can we say? I think renal denervation is going to continue to expand. In January of this year, CMS issued their TPT payment for both Simplicity and the ReCore system, essentially in outpatient settings. For commercial patients who are not Medicare, it is all but impossible to get them approved. It is just a headache, and I've had dozens of these peer-to-peers, and they never seem to work. So the questions that are remaining, I think we could say, what are our predictors of success for renal denervation? The only one I think you can really say firmly now is the higher, the more malignant the pressure is, the more likely the patient is to respond. Who's going to benefit most? Is there going to be some kind of hard endpoint reduction? Fatal, non-fatal, stroke, and MI? And what about patient satisfaction? For example, is there an effect of lack of ED for men who get denervation and don't have to take hypertension medicines? Or are there going to be a benefit in terms of side effects and quality of life for patients? So that's pretty much what I have for you. I tried to leave a few minutes for questions. I'll throw it to the panel.
Hey, Bob. Bob, can I ask you a question? I'm sorry. A great case. So I guess I have two questions. One is, for the hepatic, it's a generous artery, and the the spiral goes up to 8. Did you have a concern of the size being too big? And then I guess the second part to that question is, since we're disrupting all these sympathetic nerves, are we going to get to a point where we actually disrupt all sympathetic nerves for hypertension
I don't
control?
know. I've worried about question B before and what that's going to mean long term. But for the people we're treating now, their hypertension's so ragingly bad that I think we need to do something for them. Hepatic, the estimation visually is 8 or less, exactly like you say. But you know, for the Simplicity system, if the electrodes don't abut the vessel wall, you don't get the appropriate tracing on the monitor, and so the device won't fire, won't work. So we didn't do anything like put an IVUS catheter into C, which we talked about doing, but they had a European who had worked on this on the bench come in with us, and we felt like we were going to be okay to do that. And it actually turns out when we put it in there, we didn't even have to reset any of the electrodes. It fired away and did a great job.
Yeah.
Yeah, my question was also related to imaging. Thank you for presenting the cases. So for FMD patients, sometimes angiographically, the stenosis or webs may not be apparent. So did you consider imaging? Because I just wonder if the ablation actually maybe took care of some webbing or intramural stuff that maybe not have been pressure difference, but may have been implicated in some of their flows.
It could have, and I thought about that. I will say I did the physiology because I thought that would be, I thought that was better defined in terms of effects of treatment. Because the other thing that when you look at the papers in the physiology is what's your endpoint for dilating? So in a lot of the papers, you'll have a gradient of 30 or 40 and you dilate to a gradient less than 10. So if I see something by IVUS and I dilate, but I'm starting with a gradient less than 10, what's my endpoint? So I felt like in a way the physiology was a better choice maybe than the anatomy, but that's a good point well taken.
Hey, Bob, there's some confusion in the field because, there is, since the failure of the Simplicity 3, there's been a lot of trials, unmet, off-med, maybe unmet, maybe not unmet. There's been a lot of stuff going on out there. So what is your practice right now? You said you have it commercially available. I think that's what you said. That's what you offer that patient with the FMD. So what's your practice? Who do you think in your practice currently you're offering renal denervation to?
So I think the FDA approval is for multiple medications with resistant blood pressure, so it's a little bit open. I use 3 medications with persistently elevated blood pressure. What does persistently elevated blood pressure mean? Is it 150? Is it 160? Is it 170? Most of the people I'm seeing are well above 160 on 3 reasonable medicines: beta blocker, ARB, often calcium channel blocker, and diuretic.
The other follow-up question is that, originally we excluded patients that had atherosclerotic renal artery stenosis. Now we are much more lenient towards those. We even allowed, treatment and renal denervation. Are you doing any of that in the same setting, or do you stage them? Do you think we should be doing that? What are your thoughts about that?
That's a good. Last year I presented a patient with renal artery stent who we did renal denervation on. We have not done any in the same setting. I'm not going to debate how I feel. Subhash knows about renal artery stenting for hypertension, because I think in Coral and some of the trials, not everybody with renal artery stenosis needs a renal artery stent for hypertension or whatever. We've done a number of people that have mild atherosclerosis in the renal arteries. I would say less than visually 50% that we knew we weren't going to have to treat. are going to be tempted to treat, let's say, but we've not done any combined renal revascularization with subsequent renal denervation down the road.
And how long of an assessment do you use to assess malignant hypertension or persistent hypertension? In other words, are you doing ambulatory blood pressure monitoring on everybody, or are you using office-based or home logs?
I'm using, once I see them, a lot of them I'm seeing from other places, and they have multiple office blood pressures from referring physicians that are well above 160. And to the best I can tell, they're compliant with their medications. So I think it's good that we evaluated them so precisely and thoroughly when we were doing AFFIRM and some of the trials. But in terms of real-world commercial use, if their blood pressures in the office are multiple times above 160, and they and their family say they're taking their 3 or 4 meds, and they're a reasonable candidate, I'll offer it to them.
That's one of our biggest pet peeves is we can't do ABPMs. It's a money loser for the hospital. And to use it more than once a year is impossible. Right. Medicare pays for one, and that's it. And so I'm trying to have that bundled to some of these RDN groups so that they can have a strategic alliance with, there's several of them out there, but that would be really useful because then it allows you to follow them.
Right. Are you having any success doing your non-Medicare patients commercially?
We have a really good group, and I can tell you we have the same problem you do.
Yeah.
I've done a ton of peer-to-peers, and they always fail.
It's just a headache.
It is.
Yeah. Any other questions? I have to tell you, the only stress about that case for me was finding and wiring the hepatic. And it was not particularly hard. IMA guy found it, wired it. Have a nice day.
Thank you so much, Bob. Really appreciate you, Dr.
Thank you, guys.
Stoller,
Thank you
for your
guys.
presentation. We're going to move to the next presentation. Dr. Drew Klein, Bioresorbable Stents.
I feel like I've given this talk yesterday. All right, I'm going to try to make this a little bit different today about BRS because I think I got asked a lot of questions yesterday about how do you pay for it? Is it worth it? I think Dr. Garcia asked me that question. So we're going to talk about a little bit of a disappearing act, just like that. And so conflict of interest is none, but we're going to try to make this a disappearing act. So this is a case I had of a drug-eluting stent that was placed down below the knee for critical limb ischemia. You can see that there's a stent fracture. Clearly in the, let me go forward, right in the DES, right in here, which led to restenosis, reocclusion. And wouldn't it have been nice to just put a bioabsorbable scaffold in there and not dealt with this? Can't have a fracture without a stent. So this eventually got replaced with a new Ocero stent because I chose that, it was a little bit better. Thinner stent strut and orbital to get through, but I would have preferred to use a BVS here. So again, I showed you guys this yesterday, which is why do we need BRS, BVS, DRS, I don't care what you tell them. It's because we need to be able to leave a drug in there, leave nothing behind, and have a scaffold to prevent against recoil. Those are the 3 things you need. This is what's provided by this system of devices. Where did this come from? Well, actually, let's go back a little bit in time. There was actually a study done in the coronaries that brought forward, this was, and then it brought forward the BVS for the peripheral. So this study from a couple years ago looked at the long-term results of single-arm everolimus bioabsorbable scaffolds. And this was a prospective study between 2013 and 2018, almost ancient history now, that basically showed pretty low binary restenosis rates of almost 15%, mean length about 20. So this was kind of the basis for essentially for the Life BTK study. And here's the primary patency if you're a graph person versus words. But overall, they actually followed this up to 5 years and a 5-year primary patency rate of 90% and freedom from CDTLR of almost 90%. So I would say that that's pretty impressive. In fact, here's a nice picture of it from 37 months to 91 months BRS staying open. So I think that that's pretty impressive stuff to go out to 91 months. And motive BTK, which we'll talk about, is up to 5 years as well. So a very, very long study looking at, and that's why it was done out to 5 years, was to follow the original study. So this is currently the platform. This is what we got going on. We have Abbott, Esprit, BTK that use PLLA as a scaffold. Riva, which we'll talk about, put out motive BTK, and then R3 Vascular. There's one coming from Biotronic and Merrill as well, looking at Sirloimus, and only one with everolimus. So here's Riva's Riva Medical, basically looking at the motive BTK study. This is a bioresorbable study, looking at a different type of specific scaffold. This is a Tiracore-based scaffold. Don't ask me to understand what that is because it's over my head, but it's a different type of scaffold. The key thing about this scaffold is you can actually see this thing. It is sirolimus drug-eluting. The data is now out to 3 years, I believe now, so pretty good data, which we'll talk about. And they talk about vasomotor restoration. So really, what's been coined in this is not only leaving nothing behind, but it's allowing the endothelial to go back to where it was. Which perhaps helps us in preventing from neointimal hyperplasia, but also maybe neoatheroma. This was the CE marked, and then motive BTK RCT, which we'll present some data from. So here's the scaffold. I think here's the key thing, is you can actually see this thing on X-ray versus the PLA, which was just 2 markers, platinum markers, and then here's a regular cobalt chromium stent for you. So you can actually see what you're putting in, which is kind of nice. Standard lengths and diameters, just like everything else. And here's the motive BTK 1-year results. So primary patency rate, 88%. I do like their design here. Riva designs that disappear. Limb salvage, almost 97%. Freedom from CDTLR, almost 98%. And technical success, almost 100%. I don't know how you can't miss just putting up a stent, but it is what it is. So that's 1-year data. At CIRSE from 2023, they presented 2-year data, freedom from CDTLR 98.3%. That's return of vasomotor endothelial function. That's what was talked about at that meeting. That's what people are talking about now, is kind of saying, all right, let's get it back to the normal, good old-fashioned artery that you were born with, and limb salvage rates were pretty good. So now we're up to almost 4 years. I anticipate the study should end here in 2025. What about magnitude? Bioresorbable drug-eluting, since we're talking about innovation, this is pretty cool. Look how you can bend this thing and it doesn't fracture. So this is a different type of scaffold, PLLA reabsorbable scaffold with sirolimus, and has a different type of coating. And as you can see here in the movie, this is something that's not going to fracture in your hands, which is obviously the concern when you're holding some of these devices that are relatively a little bit more fragile. So this is another option, another player on the market, which again, the more players we're going to have, the less expensive it's going to be, right? And this is the platform, looking at the different types of details, lowest stent strut thickness, which is critical. There's no technical limitations to it, and it's actually 10 times higher elongation at breakpoints than other PLA materials. So it's got a lot of details into this technology that allows it to be able to bend and not fracture, which I think is important because, as was shown in my case, we had a stent fracture. So here's the data from Resolve 1, looking at baseline characteristics. Again, very similar to Life BTK, very similar to Motive BTK. So below the knee, relatively short lesions, like I presented the case yesterday with the TPT trunk or proximal AT. Very similar sort of idea here, 35 patients. And the data was pretty good. If you look at the data here from freedom from major adverse limb events, 100%. Safety and performance overall looked pretty good, both on angio and duplex ultrasound. So I think overall you got now a 3rd player in the field. Expect 2 others to come on board to kind of look at this. And if you haven't seen this, I want to thank Sahil Parikh for lending me a lot of these slides here. And on the panel here, Dr. Sethi is on this as well. But this is a good option basically to review about below the knee peripheral arterial disease, how to review it. And this is a very good paper out of JSky looking at how it's concurrently treating or using these technologies. So we talked a little bit yesterday about Esprit. I'll just go back to it quickly. That's a temporary scaffold, again, using PLLA. We went over this in detail then. if you look at the multi-bias or randomized controlled trial that was presented at Viva and TCT, again, and published in the New England Journal of Medicine, that there are two major endpoints. And I want you to remember these two endpoints because I'm going to talk about the cost analysis that goes with this. So there's a primary efficacy endpoint and there's a safety endpoint, all right? So the safety endpoint is major adverse limb events and postoperative death, and then the efficacy is limb salvage plus primary patency. So here is the primary efficacy 1-year data. Here's the primary efficacy at 2 years data. So limb salvage and primary patency, which is the main endpoint, again, almost 68% versus PTA alone. So bioabsorbable scaffold versus PTA alone, better patency with the scaffold. Primary safety endpoint, not much difference, right? So this is freedom from major adverse limb events and perioperative death. Pay attention to this because I think it's going to make a difference when you talk about the cost. And then freedom from CDTLR, which is what most of us care about, is not only is the patient alive, but do you have to go back in and do something later? It's 90% versus 81%. And that's important because that's obviously going to drive your cost up. So again, 2-year conclusions, which we discussed, it's safe, it's effective, and it works up to at least 2 years. But what about the cost? This got asked to me yesterday, so I wanted to go briefly into this, which is talk about the cost effectiveness. And is it cost effective to put these in? Ramon and Sahil and a bunch of others, basically Mark Banaka, et cetera, basically published this at TCT. Show me the money. What they looked at was something called the incremental cost effectiveness ratio. Sounds like a win ratio to me, but it's basically looking at the cost effectiveness at 1 year from a payer's perspective. And they looked at the cost of the procedure, and there was no significant difference in cost between the arms. But of course, some of this was supplemented by the company, right? So you're not paying for the device. So I don't know if this is true or not true, but I do bring it up. They published that there was no difference in cost between arms. What about primary efficacy? Remember that slide I just showed you that at 1 year, the event rate was almost 20% in the PTA, or 20% in the BTK BVS arm and 42% in the PTA arm. So that plays a factor, right? Because you're gonna have to go do something about those patients. And actually you save money if you put a BVS in at that point. So almost $7,000 saved when you're looking at that endpoint. So saving money, that's good. Your administrator should be happy about that. How about CDTLR? Well, maybe a little different story here. So if you look at this ratio and you look at that data, you're actually losing about $22,000 per BVS. Now that's interesting, that's per clinically driven target event avoided, but when you equal it out, it's about somewhere around 15,000. So the question is, in this ratio, is it gonna make a difference? And considering how much money we're spending on atherectomy, is this worth doing for most of your patients with below the knee interventions? I think for some they are, especially if you're talking about younger patients, not your 85-year-old with on ESRD who has got a 1-year mortality that's 50 or greater %, but maybe your 50-year-old smoker that has a good option for long-term, hopefully maybe they have burgers or maybe they have some other thing that you can give them a chance to come back from. But I think, we have to look at the cost effectiveness of this, and this is available online, so you can present this to your administrators when they ask you to show me the money. I think overall, it doesn't really matter what you call them. The key thing is that this was 1-year data using 1 stent. So that's the current cost, well, actually now a couple years ago, cost, showing that there was probably a little bit increased cost with BVS. As we add more stents on the market, as R3 Vascular and everybody else comes on board, you're gonna get less cost, right? So more competition. I think the technical tips are always remember IVUS. For any of these, you gotta make sure your vessel is prepped, as we've seen in other studies. And again, DAPT duration may factor pending into your patient because really DAPT is recommended for 1 year after this. I think this is a really exciting vascular space to be in below the knee because there's any number of potential technologies going on. And since this is an innovation section, I think not only looking at BVS, but also DCB below the knee is another option as well that I think we're going to see some more exciting technology that was covered yesterday as well. And with that, I will take, if this is going to work, maybe. All right, guys, this stop working.
It's okay, Drew. This is a great talk.
There you go.
Thank you. hang tight for a moment. I will ask you the final word, but I'll go through the panel, starting from June and onwards. Do you believe that all these technologies that are below the knee stents, these are going to become mainstream of treatment, or they'll still remain bailout? That means that we will only use it in situations where other avenues, which I will not name, are exhausted and or don't lead the desired result. That's the main question actually here. So
Yeah, and life BTK was designed as primary treatment, right? I think we have to keep that in mind, is that the study was designed as primary therapy. And yet I
knew
believe...
June is the brightest among us. Okay. This is the right point.
But
she's a woman, Subhash.
In this current state and age, I would bet you 100% all of us are only using it as bailout. We're not using it per the trial design.
I think this is the main question. Karen, opine. You are next most smartest amongst us. So
whatever she says.
it is going downhill, so keep going.
Well, I think I'll defer since I do venous work, but I agree with when in my time of doing tibial work, a bailout.
You will use a below the knee stent of any kind as a bailout, correct? Lawrence?
I would, I was on the steering committee and I didn't know it was a primary event, so I'm kidding with you. But here's the difference. If the pass-through codes change and you take money out of it, would it be your primary? And I think it will. I honestly think that if you fall back, and this is the problem, is at $22,000 of a loss, the question is, despite having what ends up at 2 years being a 33%, one in three PTA arm is open, and you do 40% to 20% for reinterventions, right? It seems to me that that money loser is based on the cost analysis of the stent. If the stent cost is bundled and you get a better DRG on it, I think you're going to see that number truncates. And the quality of life, but more importantly, cost analysis has to go in favor of the BRS. That's just my opinion.
Well, I mean, I think there's a fundamental problem here, for full transparency, in my opinion. The fundamental problem is that we are a fee-for-service health system. And when we're doing an intervention, we think of that moment. We are not thinking about the patient coming back, meaning that if I knew I was going to get punished financially or in some form for the patient coming back, my strategy maybe would have been different than if I know that, okay, I'm going to get punished now because my administrator is going to yell at me and tell me, why did you use a $3,000 stent and 3 of them in one case? So that's one point. I think is the business model that's currently in the United States is not aligned. The other problem with this technology is that we do have a technology that's very similar. It's not resorbable, but it offers drug and it offers scaffold. We don't have indication for it per se, but there's a lot of data. It's not like there's no data. There are multiple trials that have evaluated that technology, and the cost, as Peter Sokos said yesterday, is 10 times lower. So I think those are the main challenges, honestly, for this technology. And unless it's somehow at rest, the business model is at rest, and also the cost differential is at rest, it's going to be a bailout for us.
So, full disclosure, I work with the person who's PI, so I've probably directed some of the questions.
And you're on that paper where it said that you should use BVS, so.
Yeah. So full disclosure, it's all out there. But and also we're part of the post-randomization study, so we're able to recoup some of the cost of the treatment by enrolling the patients in the study. So, but I do think that the delta in patency is hard to ignore between PTA alone, although this is certainly not compared to drug-eluting stent, and also for particular lesion subsets, particularly focal lesions in the TP trunk, it performs really, really well. So for particular lesion subsets, I will use this as primary treatment, but with those caveats that I mentioned.
Drew, what do you?
I have no conflict of interest here, so I agree with the panel that it's great for bailout. I think if you're crossing chronic total occlusions in the TPT trunk, or especially the AT, trying to go back through, I want to leave something there. And if I'm looking at a bioabsorbable, if I'm going to look at a DS, it's going to come down to what's going to be easiest to get. I agree, Lawrence, it's going to change as that bundles occur. I think if I had an option and all costs were equal, I would go BVS. But right now, I'm probably going to go DES.
And I think we are actively collecting this data in our registry to see where it gets used, because I think reverse that if we start using it mainstream, more products will come to the market that will quickly drop the price from this astronomical. So I think use sometimes has an implication. So thank you very much, Drew, again, enlightening us. Let me invite Dr. Karem Harth to speak about next generation DVT devices.
Oh, thank you. Okay, thank you so much for the invitation and the honor of being amongst such amazing speakers here with me. So I'm going to talk about next generation DVT devices, and these are my disclosures. So when I was thinking about this, because we had this talk last year too, but I wanted to kind of think about it a little bit more broadly. And really when talking about the next generation in DVT, I think we've got to talk about the spectrum of care in DVT. So that involves thinking about diagnostics. Do we have potentially more improved, better devices for diagnostics? Medical therapies certainly are changing. That won't be the focus of the talk, as well as the ability to make compression therapy better, accessible to patients. And then, of course, when it comes to devices, we're thinking about the interventional part. Do we have the right device for acute patients, chronic patients, and the in-stent thrombosis? And certainly from a surveillance standpoint, some of the imaging questions come up here. And so you really want to think about what does the entire spectrum of DVT care mean when you think about devices. So for this talk, we'll primarily focus on the diagnostics and intervention. So some really interesting work in this space. So DVT, primary modality for diagnosing is obviously a duplex ultrasound. As we know, has very good sensitivity, excellent specificity for the diagnosis, plus or minus with the use of D-dimers. However, this can be quite time-consuming for the vascular lab, for your staff. There's some overwork issues, increased waiting times for the patients as they're hanging out in the emergency room, potentially delays in patient care, and not always available depending on your institute. And so interestingly, the negative DVT rates in hospital vascular labs can be as high as 60 to 85%. And that really depends on the population that you're studying. Is it an outpatient coming through the ED? Is it an inpatient who has higher risks? So there's a question of, can we replace the majority of standard ultrasounds orders being otherwise negative with an AI-assisted scan performed by a trained nurse? So can you remove the burden of this imaging from your vascular labs and bring them to the bedside to the patient? And so there's this device, which I think is interesting. It's been studied over the years. It's called ThinkSono. You could see here at the bottom, it's a handheld probe connected to an Android device. The AI in this machine can understand when you are at the common femoral level. So let me also say that this has been studied in 2-point and 3-point compression ultrasound, so that POCUS approach. Once the user, who gets a 1-hour training, gets the ultrasound probe to the right location, the screen turns green, alerting the user that you are in the right place and now proceed with your compression. So it'll do that for the common femoral, for the femoral, and the popliteal. And there's a little bit of some pictures as to how to do this. So really anyone who gets a very brief training can do this. They've shown through pooled analysis a fairly good sensitivity of 90%, specificity of 87%, and a recent study done amongst emergency room population showed that all scans were readable and appropriate in quality. The AI decreased about 1/3 of the scans and had a negative predictive value of 100%, saying that no DVT was missed, and a diagnostic time that really was brought down to 37 minutes. There are certainly some limitations, difficult to evaluate the tibials and the iliac. And I should say, which I didn't explain well, the user gets the images and then it goes through the cloud to a reader. And so the reader is the one who actually gives the final diagnosis. So anyway, this is, I think, some really interesting work from a diagnostic standpoint. Currently, there's ongoing evaluation with AI-assisted pathways versus standard of care pathways in various settings and populations. So we'll be looking out for that. Okay, so intervention-wise, we talked about a little bit of the market value of things, and certainly in the thrombectomy space for the last 10 years, there's been a lot of change and a lot of innovation, which is very exciting for venous-focused devices, moving away from repurposed arterial devices to treat the venous patients and the broad pathology. This there's a lot of interest because this market share is not small, and it's estimated to be about $3 billion market. And additionally, and I think very much enhanced by COVID, there's a shift from lytic-based overnight admitting patients to the ICU to single-session type devices. So we'll talk a little bit about some of the devices that are out there and what different stages they may be at, and try to make some sense of all of these devices. And so in the pipeline, we have some that are still very much in investigational state. And this includes the helothrombectomy, which is a suction and mechanical combination therapy or approach to thrombectomy. So you'll see how different devices can use different technology. And this is a 15 French device. It's currently in pre-510K, has an IDE in the Pilot and Gulf trial for PE. And really, over the last 2 years, there's been mention of DVT, but no moves towards that space. Next one is Magneto, which is a thrombectomy device called for Retrieve, which uses electric fields to attempt to attract varied age thrombi, which have a negative ion to a positive electrode with positive ions on the device, presumably causing less endothelial damage and also preventing embolization. And this uses a combination of suction with energy, currently in the first-in-human phase for PE, and discussions of DVT, but really no active moves there. One that over the last year has gone to a first-in-human use in 2025 is the Vascular, and this is first-in-human use for DVT, which is an ultrasound energy with microbubble-mediated cavitation to act as a debulker. It also combines TPA as well as aspiration. So here we have a technology which is a combination of suction, mechanical, energy, and lytics all in one. Again, in the quest for what is the best approach to treat these patients. And so there's a pending 510K for this device. So those are kind of in the pipeline early in the work. And so recent one to get 510K device for with the 16 French for DVT is Inquis Medical with their Aventis thrombectomy device. It's a combination of suction and energy-guided approach with a proprietary clot sensing technology and blood return capability, which you see here, which has been already in IDE trial for PE. And there's an estimation that around the Q1 of 2026, there might be some proceed on to to market rollout. So now coming on to what's in the market, the most recent one, Pounce has been available since, I believe, last year. Surmodics Pounce venous thrombectomy, which is a 10 French, a bit smaller caliber, which is not usually available in most of the DVT devices, with 90 centimeter length. Uses suction and mechanical to approach DVT with infusion capability. The collection basket is 16 millimeters and really directs clot to a rotational screw at the very top of the basket, which then can drill it into the device through a suction mechanism. The one to receive most recent 510K approval and already in the market is the Imperative Care, which is the Truvic thrombectomy device. It's a continuous suction and mechanical device. It's directional, so you can direct the catheter to the specific location, and uses this ProHelix mechanical assist device here in the bottom to bring in varied age thrombi and extract it into this small container on the back end, and that helps to minimize the amount of blood loss. So we'll see where these devices land in the space. And so this space is very fast moving, so fast moving that over the last 2 to 3 years, we've had all of these devices, some in the market, most preclinical on the bench, but basically they've quickly been benched or tabled and have not really gone anywhere. So I think, and this really speaks to the fact that there is a continuous, we're still in this hunt for the best device because not all devices are perfect for all scenarios. So that's for the thrombectomy, acute DVT, subacute DVT space. And then really we have still a challenge with chronic patients and in-stent thrombosis. And so this, the Revit device, the RevCore device, is approved in 2023. Some of you may have used it, some of you may know about it, but needs to be used in combination with the ProTrieve sheath. And this addresses what you see here on the top right, which is a very challenging problem and a very difficult to clear collagen-based layering onto our venous stents, which are very large in caliber. So we'll see in what patients this device works best in. It's currently under a registry status, enrolling with 100 patients to be enrolled over 30 sites. And it's really a safety and effectiveness one-arm study with 12-month follow-up, and we'll see how that fits into our armamentarium and which patients will benefit most. Similarly, this device is an investigational status, also for the application of in-stent thrombosis, as well as native vein occlusions. This is, again, investigational status. The first in-human study just happened in July of 2025. You see here an image courtesy of Dr. O'Sullivan, where they recanalized the stent and achieved inline flow. And so what's kind of nice about this, with comparison to the last one, is the coring element is in the shaft as well as the distal embolization basket distally. So it's really just one single device versus the other option, Renal, where you have to put this very large sheath through the neck and one from below. So we need more than just thrombectomy devices in DVT. I mean, the devices are great for removal of the clot, but you need other things as well. So with that, it's important to know that the venous system really requires the veins to be compliant. So there's a lot of deposition of collagen during this inflammatory process, which stiffens and damages the walls and the valves. And so there is the Bullfrog microinfusion device, which is a single device covering diameters of 6 to 16 millimeter vessels, and it can treat the vein with perivascular dexamethasone. And in preclinical studies, this was shown to normalize the vein wall in models that had DVT, so less thickening and less stiffening and collagen buildup. And here you can see how it's used. Let's say in the femoral segment, it's a little bit laced with contrast, and they're depositing it along the wall of the vein, and you can see where all the little contrast is. That's where the dexamethasone was placed. And so the goal of this is really to prevent post-thrombotic syndrome in the unstented and otherwise thrombectomized venous portions, to relieve obstruction, treat venous inflammation, and prevent valvular damage. So there's been some studies along this line, the dexterity early studies of 20 patients, which had a pretty nice range of patients with iliofemoral disease, isolated fem-pop, most were iliofemoral, 75%. Lytics were used in 52% of patients, thrombectomy in 90%, and stenting occurred in almost 50% of patients. It involved a treatment length of about 36 centimeters and 46 milligrams of dexamethasone. And while this is a little bit of comparing apples to oranges, what you see here in the graph is that when you have the patients starting with Villalta scores of about 6 to 7, at least in the dexterity studies, which again involved current day devices with current therapies, there was a significant drop in the in Villalta score to levels where there are no post-thrombotic symptoms. So, I think that that's very encouraging. And this trial is moving on to phase 2, which will be a double-blinded randomized trial of 60 patients in a one-to-one fashion, where 30 patients will get dexamethasone, 30 patients will go on to saline or placebo, and the intervention will include thrombectomy, stenting as per the operator, and the remaining vein that is not stented will be laced with the dexamethasone. Dr. Razavi, who may be in the crowd and certainly a part of the meeting, is one of the co-PIs. It would involve patients who have acute DVT in the first 14 days of presentation, include the segments noted, ipsilateral DVT, no prior history of it will be an exclusion, as well as no prior stenting, and again, the strategies per the operator, and this will be a 24-month follow-up. So again, I think it's really important to think of the spectrum of care because there's a lot of work and a lot of enthusiasm. And I think it's not just about the devices, but really at all these different levels where there's still a very wide open door for potential innovation in the venous space. And so I think the dedicated devices are very exciting. And so certainly it's important to innovate. I don't need to tell anybody here in the room why, but it is exciting because it drives competition. It drives pricing down. It gives us more options. There's more sort of healthy competition amongst our engineers and our scientists to see how much better we can make our devices based on patient needs. And so no single device meets all the needs. Spectrum of DVT care and disease needs to be considered, and the chronicity needs to be considered. Anatomic variability, we still don't have a lot of good options below the knee for venous disease. I mean, we have a lot of large caliber devices, but not a lot of small ones. And so I think it's a reasonable expectation, and these are, again, wide open door on the venous side of things. And, I think sometimes this is overwhelming. There are so many devices, but again, I think in the end, we need studies to really tell us which is the best device. But if you look up how many there are in this space, it's almost 70. And really, sometimes it's like staring at the pasta sauce aisle in the supermarket where they all start to kind of look alike. They all have the same color. You're not sure where to grab. You maybe put your hand. I think we end up getting used to a device that we're good at in our hands. So for example, that's how I approach it. And I hope that with time and with data, I'll maybe find even better options. And so anyway, I think with that, I'll end and open it up for questions.
Thank you. Thank you so much, Dr. Harth. That was fantastic. I love your approach of breaking it down to the different stages of diagnostic, treatment, surveillance, and all that. I think there is room for innovation in all those areas. For the sake of time, since we are running a little bit behind, 5 minutes behind, I'm going to move on to the next presentation, Atherectomy and DCB with Dr. Lawrence Garcia.
I just want to say that one slide of 69 products really bothers me because I only know like 3 of them. And so, I don't know. That's crazy. All right. In a similar vein, I just want to thank Mehdi and Subhash for inviting me once again. And congratulations on another great conference. And thank you for choosing such a cool place as Austin. And I meant that by temperature. All right. Thank you. So these are all my conflicts, most of which are germane to this talk because I served either as a PI or as on the steering committee for most of the trials that you're going to look at. I hate case presentations because at the end of the day, it just kind of shows you what we do, but I really want to show data behind what we've tried to figure out with atherectomy. And why discuss this? This is a very old slide from Dirk Scheinert's group out of Leipzig years ago, which showed that calcium is still our greatest impediment for the slotted tube stent design with a lot of the compression that you see in an AP. But if you do in an AP view, but if you do the IVUS, you can see compression because of recalcitrant lesions. So a couple cases here. This is one case of a heavily calcified artery that we put into reality, which you'll see the data on. The mid segment shows the device going in. And what doesn't show on that is how proud it got. And then this shows you on the right screen the PAX4 classification. It was fairly long on both sides, which then enrolled it into reality. This was the only case that actually ended up with an aneurysm in reality, so I was really proud of being the only source of that. But in some cases, atherectomy does work. This is a directional atherectomy case we did years ago. I used to call it the poster child for directional. That's mostly what we had at that time. And being able to open that up with a lot of due diligence with the directional system that is, at that time was called Fox Hollow, and now is Silverhawk. And what you can see is if you ever go to the operating room, a lot of these common femoral lesions are eccentric, and they're always in the posterior world, not circumferential, at least rarely circumferential. And so this was a real good result, and the gentleman did very well. So what about the data behind atherectomy? So we're going to go through directional, rotational, and then into, which I still believe is going to be an atherectomy device just by changing the arterial structure, lithoplasty. So this is Reality. Reality was a Viva-sponsored trial. It was femoral popliteal lesions up to 36 centimeters. Long chronic total occlusions were also included, but you had to have the duality of heavy calcium and long femoral popliteal disease that you could then treat with Silverhawk. The outcomes as tested were about 18 centimeters. Lesion lengths that were longer than 15 centimeters in this trial was about 56%. The chronic total occlusions approached 22 centimeters. It was actually a real-world, tough, challenging patient population to treat. So if you marry the two things, what we did in Definitive with Definitive AR, that married now into the calcific burdened but long lesion subset. And what they showed was their primary patency at 12 months, and remember this is about a 16 centimeter up to 22 centimeter on CTO lengths, was 76% on a heavily calcified artery subset. And that was never enrolled in any of the other trials that you know, which are going to be Zilver and all the other trials that came before it at the time of their approval. When you looked at the 12-month primary effectiveness, that 76%, and if you looked at freedom from CDTLR with Reality, it was about 93%. It came at a cost. The cost was embolization, perforation, and my one aneurysm in this trial. If you go to a rotational system, this is the JET registry. Bill Gray was the lead on this. When we did this trial, lesion lengths were, they separated out. This was just a pure registry, so it looked at those that got, at the time, the jet stream was called pathway plus or minus stent, and then they separated out the two between those that did not require stent versus those that did require stent. And you can see a difference in lesion length between 14 and 20 centimeters, with the average being around 16 centimeters. If you looked at freedom from TLR, actually both groups, and I'll try to show you why, did very well. Those that did not require further therapy, i.e. no stent, versus those that did have a stent. And the reason is the crossover for stent was that visually at the end of jet stream, pathway before it, when you finished with the jet stream, if you did adjunctive therapy and it was a recalcitrant lesion, i.e. a residual stenosis of 30% or more, you bailed out to stent. And if you did do that, the outcome with the stent, again, this was in the days of pre-DCB or DES stents, did very well compared to their colleagues that had no stent. And the overall 30-day event rate safety endpoint was quite good, but the 12-month primary patency was actually quite good overall. The probably most used device is CSI, orbital atherectomy. This is probably their best trial. When you look at calcium 360 and all these other randomized trials from CSI, there's no science behind it, never core lab adjudicated. Liberty is the only one that is core lab adjudicated and followed for a lot of years. And I think I really commend them for doing this trial. And they separated out the claudicants versus Rutherford's 4 and 5, and then Rutherford 6 played its own role. And if you look there on the left, the primary therapies were PTA. This was at the early stages of DCB, so not many people got DCB there. They only report primary patency in the claudicant group, and that's this one. It's very similar to Reality in the sense that it's about 83% at 1 year, which is similar to what we had in Definitive LE. This is laser therapy. This is from Dipple back in 2015, which looked at the primary effectiveness of lesions treated with excimer laser with therapy of PTA versus PTA alone, and they showed the benefit of the combination of both therapies, that is the combination of excimer laser versus PTA alone. Distal protection was used a lot, as again, like most things with atherectomy, you will have complications, whether it's perforation or embolization, and you can see the difference there. Whoops, go back, Lawrence. The difference there is embolization is third from the bottom, 8.3 versus 5% in this patient population. But if you look at it, this is now not primary patency. This is a TLR metric. TLR is the poor man's gauge for restenosis. And the worst of the worst of the TLR, PTA alone in this in-stent restenosis group is about 35%. So that really is awful. But when you added excimer laser, you did less awful. You were closer to 50%. So that shows you just how bad a market we have for in-stent restenosis and for really challenging long lesion cases. So now moving forward. Can you click me forward? Thank you. And if you looked at how excimer laser did with PTA in this forest plot, if you looked at it with male, female, diabetic, and so forth, all of them fall left of the line of identity, so that was benefited for in-stent restenosis of using the combination of excimer laser and PTA. What I didn't show you with the pathway system is there was a DCB group. It was by Nick Shamus. It was the Jetstream Ranger trial. They stopped it early for lack of enrollment, but it was only 45 patients, so I don't think it's necessarily something you want to learn about until they become a little bit more scientific in their data set. So in summary, when it comes to the generality of atherectomy, we still do atherectomy. There's still some challenging cases that require some form of debulking, there are various forms. You could either do directional, rotational, or you can do atheroablative. But I think long calcified lesions really do remain difficult in the endovascular treatment, particularly in the SFA. Vessel compliance through atherectomy really have shown both efficacy and to a degree safety, but you got to keep your wits about you. And each device really does have its own pros and cons. You got to get facile with one or two devices and generally run with them as you can see fit. But to marry those two devices, that is an atherectomy or a compliance change device, to a DCB, I think you have to understand that that is why DCBs work. The DCB trials, just for completeness, you had to have a successful angioplasty to get onto the DCB trials. Once you had a successful angioplasty, then you got enrolled, and that's how they got their benefit. When you really went into the real world patient population, and I would recommend that you read the global trials from Medtronic. It's probably the best core lab adjudicated data on a post-market analysis group. As you went longer, the stent rates went way up. And the reason is that they had more dissections. And so that never got into the trials for the pivotal. So DCBs really have dramatically changed what we do in the SFA. And I believe that leaving nothing behind has been our standard for many years now. I think the scientific data really do compel the discussion of vessel prep prior to DCB. I think calcium does remain an impediment to how we deliver our drugs. I think reality, Jetstream, whether or not Jetstream Ranger is going to ever see the light of day beyond 45 patients, I think will be important. And then CSI, I think, has a couple registries ongoing for DCBs as well. I think all of them can be useful, and the combined therapy is very useful for the outcomes of our patients. Thank you.
Thank you, Lawrence, and that's wonderful. You know, we briefly spoke yesterday about the atherectomy trials, including in their endpoint, in the driving endpoint, the freedom from stenting. Do you think, is it legitimate if you had to redo your studies from 10 years ago?
Yeah, you know, I think that Definitive LE had a 6% stent rate. I think Reality had was it 12%? I think it was 12%. So I think all of those things do play a role. I think where and I agree with you, I think stenting as an outcome becomes an important endpoint. Where I think we should win or lose is what I've championed for the last 5 or 6 years now, which is the failure mode. If the failure mode is complete reocclusion on a high cost system, then I think we need to readjust our approach. I think that should not be the primary therapy. We have a paper out from one of the strategics allowed us unfettered access to all of their trials: atherectomy, DCB, stent, and then and their stents are plain old non-DES stents. And the patterns of restenosis there were fascinating. Because, and you did it not only by device, but then you also did it by patient-centric. So you could look at device, atherectomy, DCB, definitive AR, for example, so you know it's now Medtronic. And then you can also look at patient-centric, people who came in with focal disease, and follow them out to their restenotic events, because they were all angiographic, and we went back to the core lab. And you'd be fascinated to find that in some groups, I'm not going to say the type of thing because we never did the final paper, but in some groups you came in with a device and you had a short lesion, a focal lesion, and it came back diffuse. Whereas in another device, which may be a high-cost device, came in diffuse and focal at follow-up. And I think that that plays a major role, and that's the cost analysis that I think, apart from just stenting, would be really remarkable to know.
Thank you. Thank you. In the interest of time, we'll move on to our next speaker. Let me introduce Dr. Aloke Finn. A word, not to embarrass him, but he's unique amongst us because he studies cardiology from a very physiologic and pathologic and specimen side. And I follow his work very closely because he tells us what's going to come in the future, not what is already here. So
oh, that's so. Okay,
use this one because that's.
Thank you, guys. That was too nice an introduction. This is the way to go forward, I assume. Yes. Okay, I guess I can stand here. Thank you very much for inviting me to give the talk here. This is going to be a little bit more different than the previous talks, more basic in terms of details. These are my conflicts, nothing really direct here. So Sirloimus, just talk about Sirloimus drug delivery. And as you all know, Sirloimus is well known to be on coronary stents. It's on every coronary stent. It won the stent versus the Sirloimus versus paclitaxel battle. It has become the primary drug on devices. But Sirloimus on a DCB is a very different thing because, as you know, DES have polymers, and we can load the Sirloimus into the polymer and let it degrade, diffuse over time. It's very effective drug delivery. DCB doesn't have that advantage. Really, DCBs have to deliver that drug in the course of the inflation, deliver all of it, hopefully, to the wall and make it stick there over time. That's a very difficult thing. And that's a case where the physiochemical properties of the drug become really important for drug delivery from DCBs, much more than from stents. Now, we all know that Sirloimus is a cytostatic drug. It really does not cause cell death to most degree, whereas paclitaxel is a cytotoxic drug. And that's one of the reasons why I think in the coronary vasculature, Sirloimus has won out. They affect different phases of the proliferation cycle. And overall, we know from the literature that Sirloimus is very much a safer drug. It has a much wider safety margin, good therapeutic range. It's very effective as an anti-restenotic. Unfortunately, it's not really fantastic for delivery from drug-coated balloons. It's generally less lipophilic, and its tissue absorption and retention is really short. So if you just put it on a balloon and you blow up the balloon on the wall, you really wouldn't get much Sirloimus to be there. Paclitaxel has advantages and disadvantages. Disadvantages are much narrower therapeutic margin, cytotoxic, but it has advantages in terms of tissue absorption and retention over Sirloimus. And paclitaxel can be in different forms. It's probably well appreciated by those who've studied DCBs that it's a complex organic drug, obviously, and it has different phases. There is a crystalline processing mode, and there's an amorphous mode. On DCBs, the crystalline mode is primarily what's used in terms of drug transfer. And crystalline form paclitaxel is more effective because the crystals are transferred to some extent better than the amorphous form, and they basically form a drug depot. That drug depot elutes paclitaxel over time and allows it to be there and have good biological effectiveness. So this is the way that drug-coated balloons basically work today. And you can see that paclitaxel uptake in the wall, whether you look at any of these approved paclitaxel-coated balloons, is fairly good. Drug remains in the wall at least to 45, if not out to 60 days, which is pretty good for a drug-coated balloon. And there's no doubt these balloons work. The DCBs, as we just discussed, paclitaxel, are effective when compared to PTA in terms of reducing clinically driven TLR. So they are effective, but you can see there's still a slow increase in TLR over time. Now the issue becomes one of crystals and paclitaxel crystals. If you think of this you would think would be a very efficient mode of drug delivery, but actually this crystal paclitaxel is very inefficient in terms of drug delivery. Only about 10 to 15% of the drug actually makes it to the wall. The rest is either left on the balloon or lost into the body, into the systemic system. And that makes it inefficient. And you ask, well, it doesn't really matter, or it doesn't matter to some extent. Well, it actually does matter. You know that paclitaxel-coated balloons have never succeeded below the knee, despite multiple trials. Some trials suggest even more amputations in the DCB arm. So this is one of the weaknesses of paclitaxel in terms of its abilities. Now, Sirloimus, as we know, has very good performance compared to paclitaxel in terms of late lumen loss. These are coronary trials. And you can see that the problems, the design goals for a sirolimus-coated balloon are, must enhance tissue absorption, right? We have to transfer that sirolimus with some sort of instant glue. We have to extend its retention using some sort of other mechanism because we can't just deliver sirolimus. And we have to protect it. And we have to really get that sirolimus to the tissue itself, target tissue, not lose it in other areas. Now, there's two sirolimus-coated balloons I'm going to talk about. One is Magic Touch, which is basically a phospholipid carrier. So this is a carrier that carries the sirolimus to the lesion itself. The balloon is coated with this phospholipid particles. These particles then are transferred to the wall and deliver sirolimus over time. Now, the solution product is a little bit different. This actually uses micro reservoirs of PLGA. PLGA is a bioabsorbable polymer, and these sirolimus is encapsulated in these polymers themselves. Those are delivered to the wall, and they basically elute sirolimus over time. This cell-adherent technology is a cat membrane. It protects the sirolimus as it's delivered to the wall and helps it transfer to the wall using some different charges. And there's different other products coming, even nanoparticle products, which use a combination of sirolimus and paclitaxel to deliver drug to the wall. This is something experimental we published recently. Now, the interesting thing about these new sirolimus-coated balloons is that actually when you look at the particle size, the size of particles coated onto the balloon, if you look at the paclitaxel products and you use an EM to look at the size of the individual particles, they vary greatly. They can be up to 600 microns in size. 100 microns is what's necessary to occlude an arteriole. So if you think that some of these might get caught in the arterial system, whereas the sirolimus-coated products are really using carriers, they're much more small in the sense about 0.4 microns to 4 microns. And this will make a difference in terms of the experimental data I'll show you. So in this particular example, the microreservoirs are only 4 microns in the size compared to about 100 to 600 for the paclitaxel products. Now, why does this matter? Well, if you compare and do an experimental model, this is a porcine coronary model where we basically randomize the arteries to Magic Touch solution, both sirolimus-coated balloons, or Agent, which is a well-known Boston Scientific typical balloon similar to what they use in the Peripheral Ranger, not really different, frankly. And we can look at histological analysis of coronary arteries in terms of the type of, what kind of effect do they have on the arteries themselves, and what happened downstream in the myocardium, downstream of the vessel treated in terms of the different agents. This is an example of what the histology looks like. You can see this is not we're not treating restenosis. We're not treating intimal formation here. These are normal arteries, and we're just looking at the histologic effects. But I want you to look below at the high power views. You can see the media there shown. And what you see, particularly for paclitaxel, is the media itself actually is replaced somewhat by proteoglycans. It doesn't look like the other types of media with the sirolimus or the POBA products. And you can see here the neointimal formation is really not different. Low injury model. This doesn't really show any anti-restenotic benefit of any of the drug-coated products, but that's expected in this model. We're looking at histology. Now, what you can notice for the paclitaxel DCB, which really distinguishes it, it has much more smooth muscle cell loss. It causes damage to the media and replaces it with proteoglycans, and that's signified by a unique aspect in terms of medial damage. Now, what about downstream emboli? You can see the interesting thing about paclitaxel, as I told you, is that the paclitaxel-coated balloon was the only one associated with myocyte necrosis and scarring. The solution and the Magic Touch and POBA had no evidence downstream in the myocardium of any scarring. Now, what about emboli? There were significantly more emboli for Agent than with the two sirolimus-coated products, and even less with POBA, as you might imagine. And here's some pictures you can see down below where I see PCB. You can see areas of scarring with fibrotic replacement. You can see areas around small arterioles where you can see little fragments of the balloon coating itself with massive inflammation surrounding these small arterioles. These are what we call emboli with some fiber in there. You can see with Magic Touch that was also present, and with solution, there was no scarring, but there were small emboli also seen, probably of not as much physiologic consequence. And you can see when we looked at this, we showed exactly what I showed you earlier. This was a clinical trial. I'm going to just briefly comment on clinical trials. I'm not going to do a lot of discussion on clinical trials, but this was a trial of a sirolimus-coated balloon in the coronary versus a paclitaxel-coated balloon, looking at endpoints of late loss as the primary endpoint. Now, late loss obviously is the amount of intimal formation that occurs at follow-up. And in this particular study, the paclitaxel balloon actually won. There was much less late loss, 0, versus 0.32 in the sirolimus-coated balloon. Now, paclitaxel is well known to cause arterial dilatation, probably because of that medial damage. But when you look at the clinical outcomes, the sirolimus-coated balloon and paclitaxel-coated balloon had almost identical clinical outcomes, showing you both are effective, but it may be that paclitaxel is better in terms of late lumen loss, but in terms of efficacy, clinical efficacy, both are really the same. So in conclusion, I think I taught you a little bit about excipient and carrier technologies and how they work in DCBs. Each DCB, even within sirolimus itself, each has a distinctive components which need to be carefully evaluated. Paclitaxel DCBs certainly have proven efficacy, but their safety remains an open question, certainly below the knee, that's true. And sirolimus DCBs appear to be safe from the embolic standpoint, but their efficacy can only be judged in human data, which is coming out. I think we'll see more and more peripheral data for the sirolimus-coated balloons. And this area continues to evolve. We will see improvements in DCB technologies as it matures. So with that, thank you for your attention.
Thank you so much. Aloke, we have a lot of questions for you. You're not going to get out of this easy, as you know.
Tell me.
We have to make a lot of prediction here. Usually Subhash is doing that work, but
not for investment purposes, for scientific reasons.
There's only science. There's only science. So here is the thing. Genuinely speaking, when we were studying these DCB balloons, the paclitaxel balloon for SFA pop,
yep.
I was like, man, there is no way these are going to work. How are we going to deliver some drug on a balloon, get enough of it to the wall of these long lesions, occlusions, calcification, and then they're going to work? And I was wrong. I want to be honest with you. I was not a believer, and I was shocked to believe when I saw some of the data, especially later on with more advanced balloons and stuff like that.
Yeah.
So what is your, do you think the issue is crystalline for this paclitaxel, meaning that if there was another way to deliver paclitaxel, would it be safer from a standpoint of embolization? Can we start with that question?
Yes, we can. I do believe you're correct, because you yourself were involved with something that you and I did in terms of using nanoparticle carriers for paclitaxel, combining with sirolimus. And we showed in that study that actually the rate of emboli was significantly lower than with the paclitaxel. In that study, we used Prevail, the Medtronic product. We compared Prevail to our nanoparticle created DCB. And in that situation, we also showed there was much less embolic debris with the nanoparticle. So the size of the particulates on these DCBs makes a huge difference to how they perform in terms of safety. Don't forget, we're going to lose, when you blow up that balloon, you're not getting 90% of that drug into the wall. You're losing, it goes everywhere in the body. So you're going to have a lot of that lost, and if it's filtered through the system instead of caught in the arterioles, it makes it overall a safer product, in my opinion.
Let me ask one more question, and I'll hand it to the panel, because, so there is a lot of excitement right now in the coronary space. Yeah. And many folks may not know in this room, but you're an interventional cardiologist. Yeah. So when it comes to, in the periphery, we didn't have high level, we did have drug-eluting stents, but it was challenging. It was long lesions, so on, the issues. Yeah. So in the coronary space, given how efficacious and how impactful drug-eluting stents have been with lower straws and all the good stuff that we are using them, where do you foresee the role of DCB in the coronary space as it relates to the field?
Well, I think the coronary space is going to be, ISR is the indication so far. Agent has that. It'll come out with solution. It's coming out with a trial at TCT for ISR. That's a given. I think the other areas are bifurcation. You can treat the main branch with a stent. dilate the side branch, treat the side branch with the DCB. That's probably another good indication for DCB. Now, de novo lesions are more complicated and they relate to the periphery. I think the indications are that heavily calcified lesions generally don't do that well with DCBs because the calcium is not going to allow good drug delivery. You may use an atherectomy, you may improve it. I think the data is not totally there yet. So I think calcified lesions are going to be a problem. I think thrombotic lesions are going to be a problem because thrombus prevents good drug delivery to the wall. So there may be de novo lesions that are more stable type lesions, less calcified, that may be great for DCBs. But there's going to be a small area. It's not going to be every lesion should get a DCB in the coronary space. Same with, I think, peripheral space. I think we've learning more about dealing with calcium, but there's a lot of calcium in the periphery. It's amazing that it's worked as well as, like you said, as well as it did.
Aloke, thank you very much. I think we will not ask you to publicly comment on which of these vehicle-based sirolimus balloons are going to succeed, but we will inquire about that at 9 p.m. at the gala, so be there. So let me, I am serious. I'm going to invite our next speaker and our last speaker, last but not the least, my dear colleague, Dr. Chadi. I can tell you the morning session that Karen and others were there on venous interventions were enlightening because I don't do that work, but we do see patients with venous diseases intermingled with arterial. So, Chadi, looking forward to novel devices in venous interventions.
Thank you. Thank you, guys, for having me here. It's hard to give this talk after Dr. Harth's talk. You know, she did a great job on it, and hopefully we'll be able to put a little bit of a different twist on it, but not much. So why do we need chronic, new devices for chronic venous disease? Post-thrombotic syndrome and chronic obstruction are poorly addressed. There are symptoms that persist way beyond anticoagulation and compression, and the quality of life and productivity are significantly affected. At the same time, we really need durable and targeted interventions. Now, if you look at a DVT and you look at day 4 and day 12 on this slide, there's really 8 days difference, meaning almost a week, a little bit more than a week. And on panel A and B, you see significant cellular infiltration that occurs between day 4 and day 12. Panel C shows you fibrin content in red, almost gone between day 4 and day 12. Panel D shows you that collagen is significantly increased between day 4 and day 12. So really chronicity happens pretty quickly in DVT cases. Now, how do I approach chronic DVT? I always do a vein mapping and CT of the vein, abdomen, and pelvis. I delineate the pelvic veins, anatomy, identify anomalies, evaluate the inflow, plan my access, and determine if thrombectomy is needed or not. I'm going to go ahead with the case of a 58-year-old gentleman who had umbilical hernia repair 5 weeks ago, and since his discharge has had significant swelling in his left leg with significant amount of pain. Now, those are his vitals. That's how his leg looked when he came to the office, and it was really significant to where, in my mind, I see those almost on an acute basis and not a chronic base, significant swelling from all the way the thigh all the way down to the foot. Vitals were normal, and he had decent pulses bilaterally. On the venous duplex, he had extensive DVT with occlusive thrombus in the left common femoral, and his right looked good. Now, I went ahead with the CT PE protocol, subsegmental PE in both right and left PAs. RV to LV ratio was within good range, so nothing really to do about this PE per se. What do I do next? How do I think about this chronic DVT, and how should we proceed? First, when we want to do any procedure, we have to prevent PE. We have to think about, is this a case for thrombectomy or not? Definitely, we always need to IVUS, balloon, stent, balloon, and then IVUS again. Now, the plan for him was as follows. We're gonna, forget about the PE, go with left popliteal axis since, his clot goes down to the femoral vein, and then go with an 8 French sheath, get a venogram, and go from there. That's a venogram coming from the popliteal, and when we look here all the way up, there's really significant clot, almost occlusive in the cranial part of the common femoral vein with very, very shy collaterals. Now, we've seen a huge boom in novel thrombectomy options, thrombectomy devices. Every company almost is acquiring or has already acquired a thrombectomy catheter. The clot retriever catheter is a catheter that has a basket in it that you just pull from the IVC all the way down against the venous flow and try to get the clot in it. The Penumbra has a very good also suction catheter. The Bashir in the vascular catheter is another one that has a pharmacomechanical expandable basket that you can just inject TPA through. The Chadi, which is almost now gone from the market, discontinued, also has another hydrodynamic thrombectomy device. Symphony uses another suction device. And the VenoCore, as you can see here on the lower right side, it has a later cut natinol edges designed for inline vessel thrombectomy. Further along, there's a flow physics, which is a new system also. Again, another aspiration system that has a proprietary distal valve that maintains consistent powerful vacuum at the distal tip. And they do that through a saline rotating up and down within the outer sheath. And there's the RefCore thrombectomy catheter. It's the only thing that we still have, that we have currently really, or one of the only things that we have for venous stents thromboses. And I've had mixed results with that one too. So the first thing we did, we crossed the obstruction, and it wasn't as easy as you would think. I had to use a support catheter and a stiff wire, but we went across without any significant issues. Then we performed IVUS to look, and I know IVUS is not a new or novel device, but unfortunately 50 to 70% of people who do venous work do not use IVUS, and it should be the standard for everybody who's doing any venous work. And you can see the clot coming from the IVC down the common iliac vein all the way down. It really helps us, determine the anatomical crossing, visualize the thrombus, and see, the size of the stent, the size of the balloon, and to use it also after we stent. Now, the question is, first, before I do thrombectomy, I need to put maybe a protrusive sheath through the neck, but in this case, because I have the patient prone, I cannot do that. So honestly, we opened another stent, and unfortunately, I could not reach, another IVC filter, and I could not reach from the poppy all the way up. So we used the argon IVC filter. That was the only thing that has a long body shaft up to 135 centimeter, I think, that we were able to deploy in the IVC prior to thrombectomy starting. So I was lucky to be able to use this newer device. I say lucky just because it's new, not because it's really anything different, but it's called the Argon, the Cleaner Medical Device Thrombectomy. It has a wire at the tip top of it, as you can see, that rotates in the vein, and you can just slowly advance it while going through the clot. Now, if you look on the left-hand side, you can see the wire really rotating freely in that femoral vein all the way up, because there's no clot or barely some clot up at the femoral vein. When you look on the right-hand side, the tip of the wire, when it reaches the chronic clot, is more stable and not rotating as fast as the body of the wire underneath. So it's trying to do rotational atherectomy or rotational thrombectomy there, but I think it needs to be a little bit stiffer for later use. Then I did a venogram that showed me maybe minimal improvement. Then I went through that clot again, and I did the thrombectomy using the Argon medical device from IVC all the way down. And following that, we had a significant amount of clot, both acute and chronic looking. And then we did another venogram, and as you can see, there is no way you can get across except by using balloon angioplasty. And I truly believe, and a lot of people say you shouldn't say that, but I really think that at this current time and era, most of chronic venous intervention really will require, at the end of the day, a good balloon angioplasty and a good stent afterwards. So we went ahead and thought about stenting. The stenting, as you all know, has to have a good flexibility and a good kink resistance. And so we used the Aubrey stent. I've had good results with it. I've never had issues with the Aubrey personally, as opposed to the wall stent before that was a little bit more difficult. And you have to put more consideration where to put it and how to deploy it. I usually deploy it slowly, as you can see here, third by third. It's a nitinol stent. I allow it enough time to take shape, and then I post-dilate it. Now, this is the last venogram here. The IVUS showed a great stent expansion and apposition. And having the stent with open cell design is a really good thing, as it allows it to, it's less likely to have a contralateral limb thrombosis or clot. Now, I brought him back the next day. Definitely, we need to get the IVC filter out, which I couldn't do the first day. And then this is, his leg on the right side the day after the procedure was done. So it's a significant improvement. It's just one day. To me, when I think about chronic venous interventions, I think this is the most important slide in my mind because we still have a lot to do. We are working currently on crossing devices in the arterial world, but not much in the venous world. And I think we need to start finding some novel devices because some of the DVT clots that are very chronic are extremely, extremely hard to go across. We do need, I think, large cutting balloons to treat and break the stubborn chronic DVTs. And I don't know, we have an expert here. I don't know if drug-coated balloons will ever have a role in the chronic DVTs. Some people say it's all clot, but we see a lot of cellular infiltration in those DVTs, and I'm not sure how much of a drug-coated balloon could help on those DVTs. Venous stents with antithrombotic coating, I know some companies are working on that, so I'm not sure when it will be going into trials, but I think it might reduce restenosis. Smart stents also has been really with embedded sensors is in the works. Some people are thinking about smart stents with embedded sensors for real-time patency. And AI algorithms, as Dr. Harth talked about before, are emerging to enhance the diagnostic accuracy and streamline workflows. But hopefully soon they will help us personalize care for patients with DVT, whether it's acute or chronic, and how to proceed with that. Thank you.
Thank you, Chadi. Comments and questions from the panelists, Karem? You are the expert here, so.
Yeah, so I think, great talk. I think one of the problems we have in the venous space is that of a terminology problem. And I say that because, and I struggle to define it for myself too when I do these procedures. We use the term chronic maybe a little too broadly, So it's a very dynamic process when a DVT acutely goes over the phases to become what I think is chronic, which is that synechiae webbing that happens and scarring, which is fully collagenized on the venous wall. And those are those chronic post-thrombotic patients. And I think the patient that is in the early phase, and the collagen deposition does happen pretty fast, I think we're catching them in the spectrum of sort of aging clot, and those are more in that subacute phase where I think, we still don't have the right device. Like, do we use mechanical? Do we use suction? Do we use all these other new energies that are being developed for this? But when someone offers a device to you, or you go read about it, even in the literature, when you're seeing the word chronic, I guess I would say cautiously read chronic, because how are they defining chronic? Did they send it to pathology and do histopathology on it? Are they looking at, like how, it's very subjective. And I think that causes confusion, because then you're not sure where the device was used or how it was used and in what setting, right? So it drives people to use things, but not really, maybe the wrong, with not the right setting. So I think just food for thought. I think from an imaging standpoint, from a study standpoint, from a drug standpoint, we still have to define devices along the spectrum of the aging clot.
Some chronic are tough to get across, and some chronic, which maybe we can call them acute on chronic, you can maybe do some thrombectomy and some balloon angioplasty and stenting. It's difficult to really, as you said, define what a chronic is, but
Like I think, in this patient, I think he presented more in a subacute presentation, and
5 weeks.
where I think that's where mechanical outwins like a suction device at the moment, at least from what we have currently with the big players on the market.
No, I completely agree. I mean, there's a big difference between a procedure, an organized clot, versus somebody who's got negatively remodeled vessels and fibrotic for 2 years, right? Those are very different, very different patients and very different technologies. My question to you and to the rest of the panel is, what we're learning as we're doing more and more venous stenting is that we have not paid nearly enough attention to inflow, right? So all of us will tend to access the popliteal. Some of us will access the tibials, but part of it is that we don't have good technologies to address below the knee and tibial veins. But how much should we be paying attention to inflow, especially in these patients where you may be putting a stent in acutely? If you don't have the inflow to support that, you're going to be in for a world of pain later on.
I've had few cases, we're talking acute here more so than chronic, where patient had really clot all the way down to the tibials. And in few of those cases, I had access tibial, put an ECOS catheter, and waited 2 days, then brought the patient back, ultrasounded, and then saw whether it's a popliteal access or a femoral access I can do to take care of the problem.
Yes, question.
We are actually focusing on luminal veins just like arteries, but fundamentally arteries are much different from veins. The most important distinctive feature of vein is venous valve. We are focused mostly on superficial vein, but deep vein valves are equally important. There are important valves in the popliteal vein one, external iliac vein, and few in the common femoral and SFA veins. These veins are invariably destroyed after after a thrombosis. They will be even if they're intact, the function is destroyed completely because they're not going to close properly. And these things will, as long as these venous valves are not working, they invariably get edema. Edema leads to post-thrombotic syndrome, pressure, skin changes. So just opening the occluded vein without addressing the valve issues is completely, I think, in the long run, it's not going to be effective. So there are some companies who are working on artificial valves placement, but that is never addressed much in a wider scale. So that's important.
I've heard about the valves being placed mostly in the iliac and femoral area because those are bigger valves than normal. And I think they were done in a pig, in the pigs and not in humans yet, maybe in humans in Europe or if anything. But I remember one case I've seen in a pig. Yeah. But they're still working on it, I think, but we're still very early in it.
Yeah, so I guess I'll say the closest to FDA approval is the VenoValve, which we were a site for and had the honor of participating in that and having some experience with. But we'll see. Certainly, it's a last resort for the no option venous patient with ulceration is the group that it was studied in, and one of the challenges is first you got to find the patient with good inflow, good outflow. You got to find the patient, or they've been treated. You got to find the patient who's post-thrombotic. There's more of those than the primary refluxers. That has the right size, because it comes in 2 sizes only. So if you have too small a vein, it's not going to work. If you have too big a vein, it's going to billow in the vein. So, but certainly an exciting therapy for the no-option patient.
Well, listen, thank you so much. I think there is a lot of good news and a lot of innovation that's coming in this area. Especially recently, I read in the medical journal, New York Times and Wall Street Journal, that our president has chronic venous insufficiency. So I think you guys are in the right business, and there's going to be, instead of 69 devices, we're going to have 690 devices. 690 devices. So please don't forget the 9 p.m. gala, and don't forget tomorrow morning, we're going to be at Bright.